Mobility Part 4, Introduction to Nursing Concepts, Martha Olson. As we look at what we need to do for nursing interventions, change position at least every 2 hours. Stagnant secretions accumulating in the bronchi may lead to growth of bacteria and resulting in pneumonia. Intake of at least 2,000 milliliters a day minimum to help keep the mucociliary clearance normal. Secretions will appear thin, watery, and clear, which is good because it helps remove the secretions with any coughing. Without adequate hydration, the secretions get thick and tenacious and difficult to move or expectorate. With chest physiotherapy, positioning helps to drain the secretions. Our isometric exercises are where the patient will tense the muscle without really moving the muscle or the muscle shortening, and it improves the activity tolerance. So when you do, tighten your thigh muscles just sitting in class, that is considered an isometric exercise. The thrombus, again, the heparin and elastic stockings, avoid crossing legs or sitting for long periods of time like in an airplane or in class. Do not wear tight clothing, especially those that constrict around the legs or the waist. Socks that go up just below the knee and they're very tight so they stay up but also cause a constriction. Avoid putting any pillows under the knees or putting the knee gauge up to prevent the sliding down, because then that blood from the lower extremities has to go up over that knee gauge, and it can encourage stasis of blood pooling to the lower extremities. Your range of motion exercises, ankle pump exercises, foot circles, doing hip rotations and knee flexion are also important for that patient that might be immobile. Sitting up in the chair, limited to 1 hour a day, and they should, while they're up sitting in the chair, shift their weight often. When we look at positioning techniques, we know that Fowler's position, your supine or laying on the back, prone is laying on the stomach, your lateral is on the side, and when you look in the book, that is one that the Potter and Perry textbook talks about quite a bit. We want to avoid those areas of bony prominences where that pressure, friction, and shear cause most wear and tear. When we reposition, we also want to think about how they were positioned the last time and get them on a different side. When the patient is lying prone, assess for complications such as increased intracranial pressure or any of your cardiopulmonary diseases. Lung expansion may be compromised, especially in the obese patient, so laying on the stomach sometimes cannot be tolerated by the patient. With any repositioning, assess for tubes. Always look for those tubes first to make sure that you know where they are and where they're going to go when you move that patient. I had unfortunately seen a patient in a hospital when I was working with students where the nurse took the patient out of his CPM or his knee machine after a total knee replacement, and the Foley catheter was entwined in that, and it was pulled out while she took the CPM machine off. When possible, ask clients to flex their knees with the feet flat on the bed to decrease the amount of friction and enable also that client to use the leg muscles to help us move them up in bed. Keep your feet in proper alignment and move the patient in one ease of movement. Also, for the patient to prevent foot drops, sometimes they will use a footboard at the bottom of the bed, or as I explained earlier, high top sneakers sometimes can work to help prevent foot drop. If in doubt, get help transferring and repositioning, and always think about orthostatic hypotension. The log rolling is completed on patients where we worry about neck or spinal cord injuries, and we want to make sure they don't have any injury or we are not causing further injury by repositioning them without keeping that spine straight. Application of information. What situations would these devices be useful? We have a lot of different things at our disposal. Most of these we do not have to have an order to use. We just know that it's within our scope of practice to reposition patients. Pillows are used there to support and keep the bones from being together, so we oftentimes put pillows between the knees, several behind the back, maybe under one of the arms to give good support. The foot boots keep the feet from being dorsiflexed. Trochanter rolls keep that leg from rotating out so you don't get a foot that is rotated out and staying that way. We use sandbags also to help keep legs in position. The trapeze bar is helpful when they're lifting or for them to help reposition themselves in bed. Think of times we would not want to use these. I know in the wound and skin unit we talked about not using the trapeze on a patient with an abdominal incision because it would increase that intra-abdominal pressure and possibly cause an evisceration or dehiscence to happen. As we look at use of the walker, make sure that it is set up so that it's the right height for the patient, that they are not extending their walker too far in front of them. Place the walker about a half a step ahead of the patient depending on how tall they are. The client then walks forward or toward the walker, into the walker to help support their balance. When sitting, make sure that the patient is using the back of the chair. They can feel the back of the chair behind their legs before they sit down. And when getting a patient up, don't have them hang onto the walker because it's very unsteady in that way. Have them hang on to or use the arms of the chair to push themselves up and then transfer their hands over to the walker for the best results. As we look at a cane, we know they're very lightweight. The quad cane, as in this picture here, provides the most support because you have 4 things on the ground, whereas a single cane, you just have one anchor of support that's being used. Canes should be used on the stronger side of the body, outside of the foot, and make sure that we keep the weight on both legs. When you look at helping a patient use the cane, remember the weaker leg moves ahead first. The stronger leg is then advanced past the cane so that the weaker leg and the body weight are supported by the cane and the weaker leg, and it shows examples of that in your textbook. So your patient had a stroke on the with left weakness or hemiparesis. The nurse is instructing the client and using the cane. You would instruct the client to use the cane on the right side because if the left is the weaker side, the cane goes in the stronger side. As we look at using crutches, you should be able to get 2 fingers between the crutch and the patient's armpit. Otherwise, they would be too tall and you could cause brachial nerve injury or damage. And so we want to make sure that they have been fitted correctly. We want to educate them not to lean into the crutches. Their elbows should be bent about 20 to 25 degrees. And then there is ways to teach them, and in lab you will be talking about how and where to put the crutches when they are going upstairs, using the stronger leg first, and going downstairs again using the stronger leg to support and then bringing the weaker side down with it. As we look at crutches, we want to remember that they're not as safe and not used as often with the elderly because of mobility issues and with ice. Walking outside using crutches in the winter is very dangerous. As we look at proper use of a gait belt, we're assuming that you've had that in long-term care with your CNA class, but if you do not know how to use a gait belt, please practice that skill in the lab. There's a special way to make sure that you put it in right, that the teeth are grabbing, and that you don't have it too tight. Think about times where you would have to alter where you put that gait belt. A pregnant woman, somebody with a new colostomy on their abdomen, you may have to put the gait belt up higher under the armpits, more on the chest, to give you some support without injuring that. A slider board is often used. We have those in the room before a patient comes back from surgery so that the slider board is ready to transfer them from the cart over to the bed. And they are wiped down then or disinfected between patients. We have a Hoyer lift. I always have 2 people in the room with me. I know some of the nursing assistants from long-term care use them independently, but I always feel like I need that second person there just in case something happens or something unexpected, sometimes even just to comfort the patient if they're not used to a Hoyer lift and they're very scared. When patients get used to a Hoyer lift, they feel much more secure knowing that the nurses are not going to drop them. This Hoyer lift should be weighted for up to 600-pound patients, but if you have a very obese patient, you will want to check what type of equipment you have that it would be supporting of that, because if it's not intended for that much weight, you could have injury to the patient. These ergonomic assistive devices are really the safest way to reposition. You can use a Hoyer lift to have a patient move up higher in bed even if you don't have enough help or are unable to lift them without causing damage or injury to your back or to them. The easy stand or stander is used often for patients that are unable to stand fully. We're able to lift them, put them in the chair, take them into the bathroom, and ease them down onto the toilet. So they work very well for a variety of patients. The foot cradle protects the heels. On the other side, on the right side, you see what we call a foot cradle that covers the end of the bed to keep the sheets off of the feet. Anybody with gout, anybody with foot surgery, any type of thing to the lower extremity where you would not want the sheets resting on the feet, you can use a foot cradle without a physician's order. Anybody with a heel ulcer would probably benefit from that. In the one video that I have linked for YouTube, you'll want to watch that. It talks about if they fall, what are the steps we take. This is a great way to get a priority question on the test, and we think about looking at the patient. Airway, breathing, circulation. Are they breathing when we inspect that patient? Are they hemorrhaging or bleeding somewhere? Call for help. Then we want to start palpating, looking at, are there injuries to the other parts of the body? Do they have a broken hip where we notice that leg with the broken hip is shorter and externally rotated? Get a set of vitals, then check your neuro. Check your pupils. Are they able to squeeze your hands? Are they able to talk to you? Is their speech coherent? You're looking for baseline neuros to assess, do they have a head injury or another neurological injury that is very significant? If they appear to have no injury and can move, get them in a chair, get them back in bed, and then we would want to notify the doctor. In the long-term care, you always notify the family as well. Assess that patient and go off of the protocol. Many of your facilities will say if a resident has a fall, this is a protocol. You take vitals every hour for 4 hours and then every 8 hours. So when you get to your clinical and long-term care facilities, ask what is the fall risk protocol that I would be following. As we look at word mapping again, the correct order for these: kidney stones, bed rest, and urinary stasis. For this one, it's the bed rest that causes urinary stasis, where the patient winds up with a kidney stone. The second one has skin breakdown, prolonged ischemia, inflammatory skin, and immobility. And what we're looking for is the fact that you have immobility. It causes inflammatory skin from prolonged ischemia, and the skin breaks down. So just kind of a way of thinking what's going to happen, what are the complications of immobility. Try these on your own. If you need help, let me know. But I think they should be self-explanatory. This would be a good thing to do in your study groups, is to come up with what order these four should go in. As we look at the evaluation, we want to think of, was the outcome met? Was the client expectation met? Did we keep them safe, keep them from falling? Did we prevent contractures? These are words or terms that you would want to be able to use to document on. I do have in Doc Sharing the list of definitions that you should be able to pull off and help you prepare for the next exam. Our pediatric and older patients require some special considerations, as well as your patient with stroke and Alzheimer's. Your stroke patient, because of the loss of, oftentimes weakness to one side or hemiparesis, and that center of balance is off. Your Alzheimer patient, because they are so unpredictable oftentimes as they wander and they don't use a lot of safety. Our pediatric considerations, we think of the toddler's posture as very awkward because they kind of have that sway back and that protruding abdomen. Also, infants have very large heads compared to their bodies, and that's why oftentimes they will fall or have accidents as a result of this growing body. We think of the teenager that gets very long arms and legs, and they're kind of gangly or gawky and very uncoordinated until the rest of their body catches up with their growth. Our older adult, we look at the fact that it's never too late to start exercising. And with our older adult, we think of immobilization, that gradual, is it gradual or very sudden, like after a stroke? How are they tolerating that? Is there depression that goes along with that? Our stroke patient, we're going to do some practice things in class, looking at keeping them safe and how to move them, how to get on the right side to help them. And with our Alzheimer's, again, safety, as many of them are living at home or living with a spouse as the caregiver.